Thank you all for coming this morning. Today I'll be talking to you about an exciting case I was fortunate enough to be involved in on our critical care unit at Papworth. The case focuses on a patient who is being bridged to transplant on peripheral VA ECMO who we were able to mobilise. And I'm hoping that throughout the presentation I'll be able to explain the benefits and challenges of mobilising these patients and explain that with careful patient selection, appropriate risk assessment, good MDT communication, that it's feasible, beneficial and safe. So a bit of background about the patient. He was a 21-year-old male with pulmonary veno-occlusive disease who was admitted to one of our respiratory medical wards for transplant assessment on the background of rapid deterioration over the past year or so. And to give you an idea, after walking to the toilet, so a few metres on oxygen, he was desaturating to around 79%, was tachycardic at 130, and he was having syncope episodes. So after assessment, the decision was made to list him for a double lung transplant and to admit him to our critical care unit for stabilisation optimisation with peripheral VA ECMO. So this isn't the patient. So cannulation really was key to us being able to mobilise this patient because we've had patients on peripheral VA ECMO before, but both the drainage and the return cannula have been femoral. And it's that femoral return cannula in the femoral artery that has meant we haven't been able to mobilise them. So these patients have stayed in bed and invariably become weaker. So in this patient we had a left femoral drainage cannula and a right auxiliary return cannula. And it was that auxiliary return cannula that meant that we were able to mobilise the patient. And this just gives you an idea of what a femoral cannula would look like. So day one, I came up to our critical care unit to see this patient, knowing that he was on VA ECMO, but not knowing the cannulation techniques that would be used or how stable the patient would be. And to give you an idea, some of our emergency VA ECMO cases are often intubated, sedated, paralysed, and can be quite unstable. Whereas often our peripheral VA ECMO cases are just done with sedation, so they don't require intubation, and they don't require a sternotomy. And due to the elective nature, they're cannulated at a much more stable point. So happily, he looked a little bit like this. He was alert, appropriate, sat up in bed, he was enjoying his tea and toast, and he was really keen to get up and start moving. And the key there really was that he was able to be cannulated with peripheral ECMO at an elective point. So as you can imagine, I was really keen to get this patient up and going, but I was very aware that he was requiring both respiratory and hemodynamic support with the ECMO. So if anything were to have happened, he had very little or no reserve, so it could have been catastrophic. But we weren't naive going into this, and as a team, we have mobilised patients on VV ECMO before, so it wasn't that unusual for us. We just had to take into consideration the auxiliary return cannula. So we had comprehensive discussions as an MDT to see if we could appropriately manage the risks. And to give you an idea, those discussions involved our surgeon who cannulated the patient, the intensivist, the transplant consultants, our perfusion team, ECMO specialists, ECMO trained nurse, myself and my senior, and of course the patient. And we decided that we could manage the risks appropriately and that we could start rehab sessions. Okay, so we were able to start our rehab sessions the day after the patient was cannulated, and we started with quite short functional sessions to see how the patient would cope and also to see how the ECMO would cope. So we started with things like moving in the bed, sitting on the edge of the bed, standing and step transferring to the chair. And he managed really, really well. We had no problems with the ECMO, he was stable throughout, and he was really pleased to be able to get up and start moving. And we were able to progress his rehab actually almost daily, and he built up to being able to march on the spot, sit out of bed for longer periods, and he was using our Motormed chair pedals regularly. Oh no, is it possible to go back one? No.
Is there not a reverse button?
Oh, okay, yeah. Shall I just keep chatting?
It's not going back.
I'll give you that instead.
Oh, yes.
Clothes that I put in myself.
Oh, lovely. Thank you.
Thank you very much.
Oh, that's nice. So, by day 5, the patient was progressing really well. We were doing rehab at least once, twice a day with the patient, and we decided we were at a point we could advance the patient more, and we started thinking, could we mobilise the patient away from the bed space on our critical care unit? And we knew this was adding more risk, mobilising the patient. So again, we had quite comprehensive discussions as an MDT, and we decided that we could manage that risk with an appropriate team who had the right skill mix. And that team was a team of 7. So we had a perfusionist who looked after our ECMO, an ECMO specialist who looked after one of the cannula, and an ECMO trained nurse on the other. We then had myself, who coordinated the sessions, made sure everyone knew their roles and responsibilities, made sure the patient was okay. And then I had another physio or a physio assistant also supporting the patient. And then we had, excuse me, 2 of our healthcare assistants with a wheelchair behind the patient looking after the lines and also looking after our transport monitor. So that team, we had quite a wide range of knowledge and skills to be able to support the patient, and we were managing risk appropriately. And I just mention all the roles of those people to make it clear that it's not the number of heads that are involved in these sessions, it really is the knowledge and the skills that they're able to bring to be able to manage risk and to be able to facilitate safe, effective and beneficial rehab. So by day 5, we were able to mobilise 10 metres. And by day 9, we were able to mobilise 150 metres on our unit, so lots and lots of laps. And I'm sure you'll agree that that's a huge achievement. And actually on that day, the patient's family were there and they were able to watch, and that was a real boost for both the patient and his parents. And in total, whilst the patient was with us on ECMO, he was able to mobilise a total of 6 times, which was great. And he went on to undergo transplant on day 20. So was it worth it? Well, this was an exciting opportunity for us and something we hadn't done before, and we felt it really helped to improve our practice and our knowledge and our skills. But it was heavy on time, it took up lots of staffing, as I mentioned, and it did take quite a lot of coordinating and planning. But we did see a real improvement in the patient's function. He was able to do some kind of normal movement, although it was with a team of 7. And we did see an improvement in his mood, so he was quite a withdrawn chap, but he was able to start engaging a bit more, so that was a real improvement. And I have to say, I believe he went into transplant in a much fitter, stronger state than if he hadn't been able to do rehab. And I think we can safely say without the ECMO and without being able to do that rehab, he would have been functionally very poor if he had managed to go into the transplant process. So although I've spoken about how exciting and beneficial this was, unfortunately we did encounter 2 adverse events. The first was disconnection of the oxygen tubing to the oxygenator after we'd mobilised and the patient was settled in the chair. The patient became dyspneic, centrally cyanosed and desaturated. So we started bagging the patient, the crash team came. Luckily, someone noticed the tubing had disconnected, reconnected it, and within a minute or so, the patient's values normalised. Apart from being a bit shell-shocked, he was fine, and there were no sustained issues from that. The second was bleeding from that auxiliary cannula, which wasn't unexpected due to the high pressures going through that cannula in a vessel with relatively thin walls, and unfortunately the movement there. We did feel we managed that risk appropriately because the patient only moved his arm within the limits of pain, and it was unfortunately one of those things we could only manage to a certain point. But unfortunately that bleeding did require the patient going back to theatre for revision of his axillary artery, and then again for conversion to central VA ECMO. So this was a rare and unique opportunity for our centre, and something that we do hope we can repeat again in the future. Although I mentioned those 2 adverse events, we do feel we managed those risks. We risk assessed and managed those as best we could. But if we were to do this again, they would need to be taken into serious consideration. So in conclusion, I feel that with the right knowledge and skills, the right team, good communication, that it is beneficial, feasible and safe to mobilise these patients on peripheral VA ECMO with this cannulation technique. This is just some of our ECMO team. Thank you very much.